What opportunity in particular did you find in that?
Okay, thank you very much. I think it is the right time to say good afternoon. Thank you for the opportunity, and I would like to congratulate ESOG for this novel opportunity and timely session. And when it comes to the question that has occurred to me on the telemedicine, sometimes we're referring, telehealth. And before we proceed to that detail, I think as Dr. mentioned, we don't know when COVID is going to be stopped. So if you are talking about adaptation, we have to think of three major scenarios with regard to COVID. The first scenario is COVID continue with existing pace, with existing volume of, catastrophe. This scenario one. So with this scenario one, what kind of adaptation strategies that we need to follow? This is the first important thing. The second one is might be COVID no more an issue after 6 months. So that means we are free after 6 months, which is unlikely. So what kind of adaptation strategies that we need to think of? And the third one is COVID might exacerbate it, undermine the socio-economic development. At the same time, it undermines the health and well-being of women. That's why we are here today. So these are three scenarios we have to think of. So in these three scenarios, one of the most important things is technology. As to me, one of the incentive of COVID is that it pushed us, it influenced us to think differently. The comparative advantage that we have over the last several years before COVID, it doesn't mean that it's a comparative advantage for us. So that means we have to transform the way we are doing business. If we are transforming the health care industry, I think, for example, in organic setup, the first wind of transformation is culture, practice in that particular organization. The second wind of transformation is technology. So if you are talking about COVID vis-a-vis RMNSH, the critical part that we have to think of is how can we use COVID as an adaptation strategy? It's not only because of COVID, but as I mentioned earlier, because of one of the incentives is just we have to think of how can we use technology during and after COVID. If we are lucky enough, if COVID is no more an issue after several years, that doesn't mean that we have to go back and do the same kind of things what we used to do. So from that point of view, if you know, or if you remember, or just we all know that telemedicine is not a new phenomenon, but in practice, it might be new for us, but in principle, it has been said a long of time, just for several years. For example, if you find the literature, it says that in America, for example, more than 70% of the gynecologists, they are using telemedicine as one of the approach, as one of the tools to serve their clients. If you go to UK, the same kind of stuff. But if you come to in Africa, the only country that might use telemedicine at micro level is South Africa. But the rest of us, just we are talking, but we are not doing because we don't have that capacity. But that doesn't mean that we have to stop to think. But COVID influenced us, at least to start on what we have. I mean, to start on what we know and build on what we have. Whatever technology system that we have to take it as an opportunity. Otherwise, COVID might not be something that we are taking as an excuse not to use technology. So from that point of view, for example, in Marie Stopes context, I would like to give three scenarios, three experiences. For example, our home office in London, we are using telemedicine as one of the approach, particularly for early medical abortion for 10 weeks and before. Because telemedicine was not practiced in the UK, particularly for early medical abortion. But the governments, they considered most of the women, they are afraid to come to the health facility because they are afraid of, catching, the COVID. So they declared for a short period of time, women can access or can use early medical abortion at home. So Marie Stopes just come into a picture and introduce telemedicine approach. So that telemedicine approach that enabled our providers to interact with the clients, eligibility criteria, safeguarding assessment, all those things have been done through telemedicine from the doctors and the patients or the clients, they are interacting using this teleconference or telemedicine, so that after the woman, for example, if the patient or the client is eligible for the medical abortion, she can access the service, I mean the drug, through the postal office, or she might come to, based on the regime, to come to the health facility just to pick up the product, and then she will be supported by a teleconference advice. So by doing that, most of the clients in London, more than 60% of the clients, they are receiving the services through this teleconference or a telemedicine. So that means still those women who are supported by this kind of system, they witnessed it is reliable, it is safe, and at the same time it is very easy method. So most of them, they say that I'm fine with this one, but I'm advising, or I want to continue for other services even after COVID. So that means this is one of the opportunity, the incentive that COVID to bring for us to use telemedicine as one of the healthcare industry transformation. And when it comes to Ethiopia, we are using the telemedicine to some level and reaching those clients that we are serving. For example, we have what we call it telehealth center, or client contact center that's serving clients through information on medical abortion, on maternal health, child health, and family planning and other reproductive health, including HIV/AIDS. So we are reaching more than 85,000 women every year through this teleconference, telemedicine. But this is in the normal scenario, in the normal circumstances. But after COVID, we found out the number of women who have been calling us for services increased by 35%. Because they felt that they may not able to go to the public facility, but they want to get some kind of information, how, when, and what type of drugs she might, or he or she might look for the service that she's looking for. So from that point of view, the 85% increased by 35% on annual basis, on regular basis, because of the COVID. So as a result of that, what we did was we are providing counseling on those stuff which I mentioned earlier, on RMNSH, maternal health, child health, HIV, safe abortion, even to the extent of we are partnering with UN Women, and then we are reaching those sexual abuse survivors. We are supporting sexual abuse survivors through counseling, advice, psychological support, and referral. So over the last 6 months, we managed to refer more than 34% of those clients who called us for services. So because of that, those women are able to get that service. Because she before she transferred or before she referred to the nearby health facilities, we provided a regular counseling, regular advice, and at the same time first aid management. When I'm thinking first aid management, if for example someone is bleeding for some reasons, she called and she's saying, I'm bleeding, what can I do? Then our providers, they are providing that kind of counseling, and then they refer to the nearby facilities. So that's why I'm saying the first aid management. So this is the critical component that we have seen. The number of women who have been receiving telemedicine support is increasing. And as an organization, we have learned that telemedicine should be one of our integral component if you want to reach as many clients as possible. Now, the main challenge could be, if you are talking about telemedicine or telehealth, that should be supported by technology. So if you see our country situation, the internet penetration rate is around, or number of people who are using internet is said to be 24 million, but the penetration rate is very, very low. So this might be one of the challenge that if you want to reach at larger scale, this is something that we have to think of as a challenge. The second one is, of course, the mobile users now reaching about 40 million, but that doesn't mean that all of those have been using mobile for one or other reason. So this is one of the challenge. And the other thing is the frequent internet interruption, or the accessibility for internet is something which is very limited. So if you are thinking of telemedicine at a larger scale, this is one of the challenges that we have to think, and how can we address this one. And the other thing is, as I'm trying to mention, telemedicine is aligned with technology, but most of people, more than 80% of women are living in the rural part. They may not have that kind of facilities. So the challenge is, it is technology divide. So that means we are only reaching those women or those people who have that access. but most of the needy women are living in the rural part of the country. So what kind of telemedicine support that we have to think of? This is something, an assignment, is a takeaway message for us as an organization. If you want to reach the poor and it has disadvantage through technology, what are the strategies? What are the strategies that we have to think of? This is the critical strategies that the critical, what you call it, challenge that we are facing. And of course, as I've tried to mention, COVID gave us an opportunity to think differently. So if you want to make a difference in the rural women, what kind of technology service that we have to think of? This is one of the area which I would like to convey. The lesson which I would like to draw or I would like to mention is from this telemedicine opportunity or the COVID opportunity is, by hook or crook, telemedicine should be a way to go, whether at small scale, at larger scale. We have to start on what we know, as I mentioned. We have to build on what we have. So let's build on what we have, and we have to reach many women through such kind of services. So this is the lesson from Marie Stopes that we have learned. There is a huge need for telemedicine, but a huge limitation in terms of accessibility. So accessibility has to be addressed through different means. And again, the telemedicine should be considered as an integral component in the National Health System Development Program. I don't know to what extent the government has a telemedicine policy, but if that policy exists, that's fine. But I'm not sure there is okay, if that's the case, we have to translate, we have to transform that policy into action. But sometimes policy by itself means nothing unless we transform to the implementation. So in general, telemedicine is the way to go as we are thinking COVID before and after.
Thank you very much. Dr. Mahalit, so you have been coordinating the